This is a webinar on behalf of the World Federation of Neurosurgical Societies Young Neurosurgeons Forum as part of our webinar series. And today we have the privilege of talking with Dr. Marike Broekman from the Netherlands about the ethical challenges during the COVID-19 pandemic. So I hope you all are staying safe and well during this, and we're looking forward to having a really great discussion today. Thank you for joining us, Dr. Broekman.
You're very welcome, and thank you for inviting me to talk about this topic. It's weird times.
Very odd times.
We can't meet in person, but it's good to see you on a screen. And I'm glad to be allowed to discuss some of the anxieties, the challenges that we all face now because of the COVID-19 crisis.
Very good. As a quick introduction, so Dr. Broekman has an MD, a PhD, and a law degree. And she's a neurosurgeon who focuses on neuro-oncology in practice, but also ethics. She practices at the Haag Medical Center as well as Leiden University Medical Center in the Netherlands. And she also holds appointments in the Department of Neurology at Massachusetts General Hospital at Harvard Medical School in Boston, where she helps lead research on innovative treatments and techniques for the diagnosis of brain tumors, and studying also microvesicles and microglia. She's involved in the legal committee, Ethico-Legal Committee of the European Association of Neurosurgical Societies, and is a member of the Ethics Committee of the World Association of Neurosurgical Societies. She's published over 100 papers in peer-reviewed journals, and is a member of the editorial board of Acta Neurochirurgica. And we're very excited to have a little bit of an interview to start, and then more in-depth discussion about some of the challenges that we're facing ethically during this difficult time.
Yes, thank you, Faith, for this kind introduction.
So a couple quick questions just to start, especially as more people are joining. So Dr. Broekman, you have an impressive array of credentials, and I think one of the interesting ones is kind of your law degree and your balance between ethics and basic science, as well as all your clinical work. How did you get interested in the ethics component of neurosurgery?
Well, I've been interested in ethics all my life, in medical ethics. I think I was 10 years old when I had to give a presentation in primary school, and I brought newspaper clippings on medical ethics. So that shows that it has had my interest for a very long time. The ethical challenges we face as neurosurgeons, those are the ones that keep most of us awake. Once you're in practice for a couple of years, it's no longer, did I do this correctly, or I could have been faster, or the questions are, I decided to operate on this patient, was this a good choice? We thought that this would bring more quality of life, is this correct? Those are the type of questions that keep most of us up at night, and not the technical challenges. So I think within neurosurgery, those are the type of questions that make neurosurgery even more special. It's more special than many other professions. So that's one of the reasons I'm very interested in it. With my background in law, I think I'm in a unique position to not only look at these type of questions from a medical point of view, but also from a legal point of view, and it gives you a different background. And all these things combined with always, I want to do, the best I can for my patients. I think that drives me to work on ethics in neurosurgery, to work with many lovely students to bring ethics in a more prominent place in neurosurgery. So
very good. So why don't we go ahead and you can share your screen, and we can start discussing some of this, and then we'll we may pause and answer some questions. People are free to write in on the chat as we go along, especially as we're discussing different segments of ethics within the current COVID-19 pandemic.
Yes. So this current pandemic, well, we have never lived through such a pandemic before. Everyone has had challenging times in his or her life, but a pandemic like this, we've never had before. And just looking and talking to all my friends and colleagues made me realize we have all different questions, we have different anxieties, we have different hopes for the future, but there's so much uncertainty and we all deal with that differently. I think it's very good to discuss this moral distress that we might feel because of these uncertainties, these anxiety, etc. And that this discussion, I really hope that it can help dealing with that vague sense of anxiety and not knowing what will happen to us or your loved ones or your profession. So these challenges are the challenges I will talk about today. And I think I will focus on three challenges that I've heard most colleagues worry about. And one is, okay, there might be a shortage of resources. It can be we have shortage of ICU beds, shortage of ventilators, shortage of adequate testing material. There are many forms of shortages, and we need to think about resource allocation. So that's the first topic I'll discuss today. Next, I've heard many of us worry about PPE, the personal protective equipment. So is there enough PPE for everyone? Should I work if there's no PPE? And how do you think about it in the context of being a doctor? You signed up for, being a doctor, caring for patients, caring for sick patients. But what if there is not enough PPE? Do you still need to do it? When should you do it? Can you do it? Questions like that are extremely prevalent, I've noticed. The third topic I'll discuss today is task shifting and sharing. Many of us practice their profession in a bit different way compared to 2 months ago. Some of us are working from home and doing clinic over the phone. Others are in charge in the ICU department. Others are working in emergency department with COVID-19 patients. Others are still doing some neurosurgery, but can't do the cases they were used to. So our jobs have changed because of the pandemic. And this, raises several questions as well. So these are the three things I'll discuss today. So with respect to resource allocation and priority setting, the WHO has published a document online. Everyone can read this. And it starts out with all these questions that you might have as well, that I had. So there are frameworks, ethical frameworks for pandemics. For instance, there's one for influenza. So can we just copy that and paste that to COVID-19? Just replace influenza and just paste COVID-19? Well, I think that for some topics you might be able to do that. Because, we have thought about this. It's a pretty decent framework, but there are differences between influenza and COVID-19. Differences between the people that get affected. Differences that there is no vaccine versus there's a vaccine. There's many more unknowns for COVID-19. So these things make COVID-19 different from influenza. So the framework that was set up for influenza can be used to a certain extent, but not copy-paste for COVID-19. So are the ethical considerations, some will discuss with you later today, for all medical countermeasures, including vaccines and PPE, and are they all the same? Well, perhaps not. For instance, some would say it's good to think about okay, there's this treatment available. Who gets it? We don't have enough. Well, you can think about a lottery. Gives everyone an equal chance. But if you think about the ventilator, some might benefit more from the ventilator than others. Is it fair to say, well, we do a lottery system? Well, perhaps not, if you can maximize benefit in a different way. So the ethical considerations, I think, are not entirely the same for all medical countermeasures. And that's something we should keep in mind. Also, listening to my story in a bit, might be good to realize that some of the things might work for some things, and some might work for others better. And what's the basis of how do you decide who should have priority access to scarce resources? Well, that question, many before us have thought about this, and I'll discuss some of them. So some would say, well, you should prioritize worst off. The patients that are just worse off, they should be helped right away. Others would say, well, it's better to maximize benefits. You should make sure that the things will be used so that most people can actually be helped. Others say, well, it's super important to treat these patients equally. Might be difficult, as we see now that COVID-19 affects the elderly way worse than younger patients. And there's a discussion of promoting instrumental value. In some countries, people say, well, if there's a shortage of PPE, it's not that doctors should get it first. Whereas actually most countries, people agree that, well, doctors should carry PPE as they can actually help more patients if they're well protected. So it's balancing all these ways of answering this question: who should get the scarce resources? Well, this table has been published recently and republished. It was published a while ago. It's been reused recently by many, as it sort of shows the pros and cons of every way of making decisions about scarce resources. So if we think about what I just mentioned, should treat patients equally. How do you do that? There are multiple ways to do that. You can say, well, make it a lottery. It seems super fair, right? You have this drug, one gets it, one not, make it a lottery. But you will ignore other relevant principles. And yeah, the question is if that's really good. And for instance, you have one ICU bed, you have a COVID-19 patient and a patient with an epidural hematoma. And who are you going to treat? Well, a lottery system right there. I'm not sure if we should, if that's the best way forward. Others say, well, you could do like a first come, first serve. There's this COVID-19 patient, 85 years old. We take him to the ICU. And even though there might be, his prognosis might be way worse than a young patient who needs ICU care for a neurosurgical disorder, you say, well, he was first, so he gets the bed, the younger patient dies. So it does not fully take into account all other things that are important for patients as well. So, and it's sometimes literally the ones that live closer to the hospital get the best care. So that might not be the best solution either. Well, what you could do is then trying to favor the worst off. But then the discussion is who is actually worst off. So, and is it worst off now or is it worst off in the future? And again, it's you don't take into account all the other relevant principles. Some would say take the youngest first. They have the longest to live. You can win most by making sure that the young epidural hematoma patients get treated. But then you don't take into account all other principles. So that can work, but it's challenging, especially for COVID-19. Others would say, well, we can focus on maximizing benefits. What measure will create the most benefit for the most people? Well, what is that? You can think of, well, optimizing the numbers of lives saved, or you can think about the prognosis or life years saved. And in that case, you would perhaps favor a younger person over an older person. And so there are all these things that it seems pretty clear, maximizing total benefits, but then there are still decisions that need to be made. And there's this instrumental value. If you can save people who can contribute to science, if we make sure that there are ICU beds for those patients that actually partake in studies, or that there's enough PPE for healthcare workers so that they can help extra people. In general, that's a sort of accepted, but it still poses some challenges as well. So this table from a very good paper in The Lancet, I think, well, describes sort of the ways one can look at scarcity and how you can actually think about allocation of scarce resources. So how do you make these decisions? Because I said, it sounds simple, maximizing benefits, but then number of lives saved of number of life years saved. Well, that's a hard choice. I think it's very important that these choices should not be made by an individual doctor. You don't want to be on call and having to make these decisions. You want a team. You want to make this decision in a team, and preferably you preferably want to have guidelines from your hospital, your country, or your international society. So I think it's important that we continue to discuss allocation of resources also within the neurosurgical community. And how do you make them? I think it's very important that one is transparent. It should be clear to everyone involved. So this and this is how we made these choices. I think it's important that every stakeholder gets included in making the decision. You can't make this decision about ICU beds without your ICU doctor, without your neurosurgeons. You need everyone on board to agree. You can't say, this time we do this, next time we do that. No, it should be sort of consistent. And people that make the decision, or the organ that makes the decision, should be accountable for it. So for how does one deal with scarcity? I think it's very hard. Let's hope that not many of us will have to deal with challenges like this. But in case you do, always make sure that you have the backup of a team that's not the individual doctor. Make sure it's transparent, inclusive, consistent, and that the organ is accountable. And then think about the different ways one can allocate resources. So I mentioned the second thing that I got questions about was, in my hospital, there's not enough PPE and I still need to do my job. Fortunately, in my hospital, that's not the case, but questions like this I have been asked these questions. It's hard. You are a doctor. You sort of feel that you have a duty to work, a duty to care for sick patients, a duty to do the best you can, a duty to show up. At the same time, it's not only about your duty, but it's also about consent. What should your employer do? And I think if in case there's not enough PPE, you can't be forced to do your job. Because many parties in you going to work, there are actually many parties involved. You have a duty to yourself and your family. If you fall ill, you can't help others. So that's also a duty to other patients. If you fall ill or get COVID-19, you can become a super spreader, especially if there's not enough PPE. You run the risk of actually bringing COVID-19 not only home, but also to your other vulnerable patients and their families. So that is actually a reason, could be a reason to say, I'm sorry, if there's no adequate PPE for me, I won't be doing this procedure, for instance, or not, I won't be seeing these patients. You have a duty to take good care of yourself as well and your family. I mentioned already for your patients, you don't want to become the super spreader. And if you're sick, you can't be the doctor you can be if you're not sick. And you don't want to be the vector to make them sick. Hospitals have a duty to make sure that doctors can safely work. But you also, as a doctor, have a duty towards the hospital. That's important that patients get access to care, that hospitals can continue to treat patients. But you can't afford as a hospital to have all these sick nurses and doctors, etc. So therefore, it's the duty of the employer, the hospital, to actually make sure that there's adequate PPE for their doctors and nurses. And last, there's a duty to society. You trained as a doctor. So as a society, you have this obligation towards society to actually help as many patients as possible. But again, if you fail, then the whole doctor, you can't function as a doctor, and the commitment, you can't commit yourself to doing that. So there's also a commitment of society to making sure that there's enough PPE for those that work with COVID-19 patients. The third thing that I was asked about, and I noticed that caused a lot of anxiety among various colleagues, is actually doing a job that you're not trained for. So this does happen in neurosurgery. It happens often happens in some low and middle income countries where there are not enough neurosurgeons, and general surgeons or others have to perform neurosurgical procedures. How can one do this safely? Well, there are actually two ways of doing this. You can actually shift a task. So you say, okay, there's this subdural hematoma, needs a burl, and you transfer the clinical autonomy to someone with shorter training or fewer qualifications. This is called task shifting. In contrast, there's task sharing, and this uses different models with collaborative teams of specialists and less qualified people who share the clinical responsibility and rely on good communication and training, and just to make sure that there are high quality outcomes. So what we've noticed now, that the situation with COVID-19 is somehow similar, but also dissimilar. Neurosurgeons are not now the ones whose task gets shifted or shared, but they're actually on the other end. Neurosurgeons and neurosurgical residents have to do jobs that they were not trained for to do. Neurosurgical residents as well and neurosurgeons are facing challenges that are unknown, not only unknown to them, but unknown to the entire team. So also the internal medicine residents don't know everything about COVID-19. ICU specialists also have a lot of unknowns about COVID-19 and still need to work together with neurosurgeons and neurosurgical residents to make sure that everyone is taken good care of. So what we've known from faith research is that task shifting and sharing usually follows three phases. There's a training phase in which the person who gets a new job makes sure that he gets all the skills to do that job properly. Well, in case of COVID-19, we've seen different things. Training was usually extremely fast and many times on the job. So what happened is some people were asked to work from home, and some were asked to help out in the emergency department. Others were asked to help out in the ICU department. So there was a reorganization of teams to make sure that everyone could work at the top of their training. There were webinars and skills workshops to make sure that that everyone sort of knew about the specific COVID-19 care. There was training on how to wear the PPE and how to dispose of it, and in some places there were even PPE coaches, and in some cases there was like some sort of evaluation before starting. But most of these things, most of the times, we noticed that there was directly a practice phase. So they just had to do the job they were told to do. So what is it, practice phase? What does it look like, and what did it look like in some countries, and does it look like in others at the moment? We see a reduction in neurosurgical cases. Why? To make sure that for its part of the reason is the resource allocation we just discussed. So we made sure that everyone could work at the top of their training, but still having to deal with the scarcity of resources. The practice phase for some was like establishment of a clean team versus a contaminated team. So some teams could come in 1 week and the others the other week, so that you always made sure that that no one would fall sick. We saw a lot of collaboration with other teams, and it was important that it was very clear who should you ask for help in case you're faced with this new position. So the last phase in task shifting and sharing, and in general, it's important to realize the more you share, the better it is. You want you want the least amount of task shifting, and it's best to do task sharing in cases like this. But the last phase is the maintenance phase. So how to ensure that you can keep on, if you have all these new workers all of a sudden that are not trained at ICU, docs or nurse or whatever, how can you make sure that everyone can continue to keep up? Well, it's important that there's access to information, adequate training, and that there's enough PPE. It's important to realize that having to do a different job than you're trained for can give a lot of moral and physical and mental distress. And it should be recognized that it's not a weakness to admit this, but it's a given. And teams and hospitals need to make sure that this gets the attention it needs. I think it's important that there are also like green zones, so that some of the emergent cases, especially in the maintenance phase, you can still do some neurosurgery. And we'll discuss in a bit how does one decide what type of surgery can be done and what is best to postpone. And it's good to continue the neurosurgical and system research, etc., to make sure that the system won't collapse during this pandemic. Well, we all hope that this pandemic will pass, but we don't know when. We are in it now, and some countries have seen the peak of the first peak, or let's hope there is no second or third, etc. But some countries have seen a peak. And this is the graph that I downloaded yesterday for the Netherlands. And we see here that it sort of seems, this is the cases that were reported. And what you see is that there is what it looks like there seems to be a decrease in the number of patients that were reported. So we might be past the first phase. I notice around me that we start thinking about, okay, what's the future going to be like? How are we starting our neurosurgical practices again? Well, how do we negotiate the new normal? It's clear that we still have too many patients in the ICU to completely return to normal. Still, most of the hospitals are still, at least partly, devoted to COVID-19. all these new patients, the hospitals and the teams were not built for so many extra patients. So it's, for one thing, it's sure that we can't return to normal as it was, as we would call the situation 2 months ago, overnight. We really need to think and negotiate how we will start up our practices, and making sure that it's solid and that we care for our teams. Because if we get a second peak right now, I'm really afraid that everyone who had a new job these past weeks will just fall sick, will collapse, etc. So I think our hospitals can't take our peak right now. So we really do our utmost best to prevent it. So how does one make the decisions? What cases to do, what not? We published with the ENS, we published a list of procedures online that preferably should be done within a 6-week time frame. And I think that's a good basis for decision. If you decide to open up your neurosurgical program a little bit again, how does one make the decision? Well, I think we all agree that it should be relevant. If you decide to start with cases that you can discuss if they should be done at all, perhaps that's not the best thing to do. So I would recommend take a peek at the list published on the ENS website and see what type of surgeries should one preferably do within 6 weeks. Basically, those are the procedures that prevent a greater neurological deficit or death within 6 weeks. So start with those. It should be relevant. It should be transparent. So using a list like that can actually help. Okay, so these are our criteria, and it is clear to everyone how these decisions will be made. If someone does not agree, it should be possible to appeal. Should be say, hey, I don't agree with this because this and this and this. And that should be possible. And there should be some sort of, okay, we should continue to reflect and think, is this really the best way we do it? There should be some oversight. We should see if we can improve this. And only if we do it like this, completely transparent, I think we can start to slowly open up a little bit again our neurosurgical practices at some point. But I hope it will be in the near future for some, and some also near future for others, because it's important to realize that patients that don't have COVID-19 also deserve care. It's not neurosurgical patients, and I think that's our duty as neurosurgeons to make sure that we vocalize the needs of neurosurgical patients, even if they don't have COVID-19. But our patients need our help, and that's what we can do, making sure that they get the help they need. So therefore, it's important to start thinking about how do we negotiate the new normal, making sure that our neurosurgical patients get the care they need. So I discussed a lot this afternoon. I discussed that many of us feel some form of moral distress, that many of us feel this anxiety because of the COVID-19 pandemic. We discussed that there are many concerns, including research allocation. There are not enough ICU beds. How are you going to triage? We can only do one neurosurgical procedure a day. What type of procedure are we going to do? There's not enough PPE. Should I still go to work? Can the hospital force me? What's my duty to my patients? Can I make my patients sick? So these are concerns that I've heard over the past weeks. And there are concerns about doing a job that you've not trained for. It can be heavy, it can be tough, but it can be done even in a ethically and psychologically sound way. So if you think about the ethics frameworks that I showed on these slides, I think these frameworks like this can actually help navigate these concerns, these challenges, and can help us making decisions. Some of these decisions should not be made by an individual doctor, for instance, those on research allocation. But some you might face as an individual doctor, and then it's nice to fall back to these frameworks. If we are thinking about opening up our neurosurgical practices, it needs an active attitude from everyone involved. Communicate with your colleagues, your patients, everyone. And it should be built, that negotiation should be built on 4 conditions: relevance, transparency, appeals, and oversights. We're facing uncharted waters right now. Everyone's in distress, but only if we work together, team up, dare to vocalize our concerns and anxiety, I think, and uncertainty, I think we can make it through this pandemic, not only us, but also our patients. And if we just strive to be the best version of the doctor we can be for our patients, I think we're already doing a pretty good job. Well, thank you so much for giving me the opportunity to discuss all of these things. And I noticed that there are already some questions. So, Faith.
Yeah, thank you, Marike. This was a tremendous overview, and it's really helpful to see frameworks that have already been kind of established, as well as adoptions and adaptations of that for the current pandemic. So one question, I mean, we have viewers from all over the world, and while it started in China, Europe was really the second continent and area very much hit by this. So in some ways, you're ahead of the other countries where the virus has not yet reached its peak. You discussed that chart with a lot of different approaches to these frameworks, prioritization, utilitarianism. What have you seen in terms of allocation of hospital beds, or even which surgeries are continuing to proceed in neurosurgery in the Netherlands? Like, which frameworks do you feel like are most being applied right now?
Right now, it's a little bit of everything what I've seen. Interestingly, whereas most doctors just try to do the right thing. They try to take care as good as possible of this individual patient. Remember that, for instance, if you hear about a case on paper, you'd say, no, don't do surgery. You walk into a room, you see the family, the patient, you're always, the rule of rescue takes over and you want to do something. But I think, so what we've seen is that individual doctors argue for individual patients. But at the same time, we as a society opened up this discussion. So we built many ICU beds over the past few weeks. We had many discussions with people over 80, with a lot of comorbidities. We had conversations with them. Okay, you have COVID-19, or if you were to get COVID-19, would you still want to go to the ICU? And actually, most patients, or people that are not patients yet, would say, no, I heard 3 weeks and this. And so I think what we've seen is triage basically before going to the hospital. We've seen triage within the hospital, being admitted, yes, no. And then within the hospital, we've seen the triage. So I think that's the types of triage we've seen. I think all principles were used. So sometimes we chose to just making sure as many people got the resources as possible, whereas in another situation, we made sure that at least youngest patients got treatment. Whereas I think, basically what I want to say, I think all measures, all ways of dealing with resource allocations have been used. Mm. We have not seen in the Netherlands a prioritization of healthcare workers. Mm. But unfortunately, well, for ICU beds, etc., we did not have to. So
if a middle-aged patient with a glioblastoma came in through your emergency room, what would the process look like in your hospital of getting that approved, or what what frameworks would you apply? And as an attending neurosurgeon or consultant neurosurgeon, what do you have to appeal to an ethics board, or what's ongoing now? And then what do you think is more of an ideal structure?
So you ask about what would happen if our glioblastoma patient were to come in right now, right?
Yeah.
So I'm very fortunate. In my hospital, the glioblastoma surgeries were some of the few surgeries that could be done actually. We made ICU specifically for post-op patients. So that's the reason we could continue to do these surgeries. However, if one of the glioblastoma patients were to catch COVID-19, we know that prognosis would be not so good. And I'm afraid, well, you always look at, the life expectancy, etc. So if you had to choose between a glioblastoma patient that had COVID-19 versus someone without this comorbidity in COVID-19, I think, well, we all sort of know what the decision would have been in that case. Fortunately, we did not have to make that many choices like that, but it is something that many patients suffering from glioblastoma, for instance, were aware of. If I get this is really bad. So I could still do those surgeries. So yeah, I can't talk from personal experience.
Do you have any comments on how maybe other institutions are doing it, or how you see this going forward? Do you think that more of an assessment about the DALYs or QALYs will come into play in terms of prioritization, like the surgeries that will translate into longer life lived? Do you think that will start to play a role, or do you think it won't really get to that point?
So that's maximizing, QALYs, for instance, or dailies, or, so those are our options as well. And I think that if shortage increases, if in Holland, for instance, we get a second wave right now, a second peak, then those are principles that will be used indeed. And then, we have to make these calculated decisions. Especially if you don't triage before going to the hospital, within the hospital, who to admit, and then if someone deteriorates for ICU admission, you'd have to make it, you have to base it on principles like that, yes.
And in your hospital, have you seen, you talked about multidisciplinary teams making these decisions together. Are they involving patients on those panels, residents? Like what do you think? We have a lot of young neurosurgeons who will be watching this. So residents and those within 10 years of practice, what do you feel like is their role in getting involved in these committees or advocating for their patients?
Well, absolutely. Some hospitals have committees like this already. Some are establishing them and some are not interested. So as young neurosurgeon, I would encourage you to be involved. And if there's for instance, in my hospital, there was no committee like this. So I'm actually starting it because I think, you don't want to make these decisions as an individual neurosurgeon. There will be national guidelines in Holland, but those guidelines, they're guidelines. They won't tell you what to do in a specific situation because the situation is never exactly like it is in the guideline. So it needs interpretation. And that interpretation should be done by an individual. So if there's no such committee in your hospital, start one, really. No one will say, no, we shouldn't do that. I think it will be appreciated. So please get involved. And what you can do is, I realize that many people might feel a bit powerless because of this situation. We're not trained for this. We're no ICU doctors. But you can do certain things. You can advocate for your patients. You can make sure that a non-COVID-19 patient gets the same care as a COVID-19 patient. If we just reserve all the ICU beds for COVID-19 patients, where will your glioblastoma patient go after surgery if there's no room to do that anymore? Where will your epidural hematoma patient go? So we have to make sure that you continue to to discuss with the rest of the hospital the challenges that neurosurgical patients face and the needs of those neurosurgical patients. So it would be ideal to have patients on board, but it would be super hard for every specialty, a different patient perhaps, or someone speaking. I'm not sure if that's possible, but it's good to realize that every patient wants and deserves the best care he or she can get. And we have to continue to be aware of that.
Also, I want to comment, everyone watching, you can write questions into the chat and then we'll bring them up as they come in. One of the things I think I'd love to hear your thoughts on is that in terms of prioritizing healthcare workers, or even with health disparities and access to insurance and healthcare, what do you think are the ethical challenges that await us? One thing is, as more countries are moving to serology testing and access to that as an immunity passport, if a vaccine is to be developed, what do you think are some of the other ethical challenges that maybe we haven't seen just yet, but could easily be a potential in the next step?
Yeah, there are so many, and there's so many unknowns. If you get a vaccine, who gets the vaccine? Are those a prioritization? Should we prioritize healthcare workers? Should we prioritize those who contribute to research? If yes, what type of research? COVID-19 research or non-COVID-19 research? When do you contribute to COVID-19 research? If you're a healthcare worker, is the cleaner in the hospital not just as important as doctors? You know, so sometimes it sounds okay, we prioritize, but how exactly? So this will pose challenges. It might increase. If there's a vaccine, we have to make sure that there's the principle of justice, that to keep in mind the principle of justice. Why should someone who earns a lot more money get a vaccine and someone in a different socioeconomic position shouldn't get a vaccine? No, treat everyone as equal as possible. So I think it's very important that if there will be testing, there will be vaccines, etc., it might be of interest to society to prioritize healthcare workers so that we can at least continue to take care of all patients, which might increase the benefit to all. But at the same time, we should be super aware that it's not something that's like only for certain groups, etc. If you prioritize, do it on basis of, okay, who's at the greatest risk? Perhaps that might make sense. Perhaps we should start with people, vaccinating people over 70. Those run the greatest risk, and then other things. So I think in the near future, in the next couple of years, there will be many, many challenges. Also with restarting surgery, who do you start with? You have 50 patients on your waiting list for a disc. Who will be first? Are you starting with the mom of 3 who needs to take care of their 3 children? Or do you start with the director of a big firm that will otherwise go bankrupt? How do you prioritize? So I think we'll face many, many challenges over the next weeks and months to come.
All right. Angelos, you were writing in a question, Angelos Colias from Cambridge. Would you like to, I think I can unmute you here.
Hello. Hi.
Hi.
Hey.
Hi, Marike. Thanks very much for this excellent talk.
Thank you.
It was fantastic. You know, I guess the question that I had is that I think, as you say, we have to remain advocates of the needs of the patients with neurosurgical conditions, and obviously, you know, this needs to be balanced against the needs of patients with COVID, especially those who need hospital care. But I think as the minimum, we should carry on providing at least urgent emergency care. What are your views? I mean, are you aware of any issues with provision of urgent neurosurgical care? You know, I don't know, from any contacts you might have.
So I'm not aware of hospitals stopping all neurosurgical care. So I'm not aware of hospitals not clipping like ruptured aneurysms or doing like emergency shunts, etc. As far as I'm aware, that type of care still continues all over the world. However, there's many of the things we do in neurosurgery are semi-urgent. You know, how long can you wait for someone with a cervical myelopathy? Mm-hmm. I mean,
yeah.
It's also urgent, but we call it semi-urgent. So I know that in some countries or some centers, they've stopped things that should ideally have been done within 6 weeks. And now these 6 weeks are almost over. So hopefully they can restart cases like this again. But that type of surgery was paused in some centers and some countries, especially those hit hardest by the COVID-19 pandemic. That is challenging, and it poses a lot of questions also with respect to, you know, how you collaborate within Europe, for instance. If some centers don't do glioblastoma surgery and others do, how should we go about this? Can't we somehow work together to make sure that all neurosurgical patients get the care they need? So to answer your question, no, I'm not aware of centers stopping all urgent care, but there's discussion about what semi-urgent is and what is still a little bit urgent. And that's exactly the population that I fear for in some centers and countries. And I think as a neurosurgical society, we should work together to make sure that those patients don't fare worse because of this pandemic.
Yeah, I fully agree. Thanks. That's a very good answer. Thanks, Marike.
All right. If other people have questions, you can continue to write in. When Marike, when you were helping make the EANS guidelines for what is urgent and semi-urgent, did some of these things come up, or was it more just based on the other social factors of a patient or demographics, or was it purely based on pathology translating to, you know, deficits if not operated on urgently?
That list was purely based on medical conditions. If someone would not have been operated, would fare worse because of the delay. That was the basis for the decision to be on the list in a certain place on that list. So yeah, it's pure medical.
Mm-hmm. What about, so I know within our skull-based surgeries, there's thought to be a higher risk of contracting COVID due to aerosolization. Mm-hmm. And if as an attending or a young neurosurgeon, a patient comes in with that case, what are some, thoughts that might be going through either the neurosurgeon or the resident's head, and then how would you advise them kind of walk through that?
So what would you do in case of this? I was reading Gil's question at the same time, so I will come to that as well. So what would you do for the endonasal surgery, for instance? Mm-hmm. Well, it's actually a challenge because you put yourself at a greater risk as a young neurosurgeon doing these procedures. There's a lot of aerosolization, so you should be super careful and only work if you can get the proper equipment and feel comfortable about it yourself. So some of these cases can actually be postponed for a couple of weeks without harm or additional neurological deficit. Some can't. So that's first triage decision you need to make. Does this really need to be done now, or can this safely be postponed? Then is there the protection that I feel I need? And if not, can you somehow arrange it? And if not, then yeah, it's hard. If you have to make the decision and weigh all pros and cons, and those include, taking care of yourself, your family, other patients, etc. If you were to catch COVID-19, versus helping that individual patient. So it's a hard choice. It's even harder if you're a resident and your attending says, "Here's case, go ahead," because that. Yeah, in some centers, I'm afraid that the resident will just continue to do it. So we'll have to do it. We'll feel forced to. So I would question, in that case, I would question the attending. Why don't you do it yourself, please? And yeah, you're your own agent. So please make sure that you feel right about this and vocalize your concerns, even though sometimes the relation is a bit hierarchical. So it can put you in a difficult position, a case like that.
We have a question coming from Dr. Gail Rousseau. Gail, I've unmuted you if you'd like to ask this, or we can read it for you. All right. So Dr. Rousseau is asking if you can address the ethics we face in global neurosurgery as the pandemic gets more serious in low and middle income countries. Do you have any specific suggestions for actions that organized neurosurgery should take, for example, as the pandemic becomes more serious in Africa?
Well, yeah, it's something of great concern, I think, to everyone. I think if the pandemic were to spread in low and middle income countries, well, the risk of a very even more severe outcome than we're seeing now in Western Europe, etc., is actually quite high. What can we do? First of all, we were just discussing if you should do a case without proper protection. I think that will be one of the first concerns. Is there enough protection for the surgeons there, for the doctors there? The next question is, can we make sure that there are adequate beds, hospital beds, ICU, ventilators, etc. There is a scarcity of resources in many countries. There will be an even greater scarcity of resources. How to navigate that? I think we really hope that that the situation will not come. So I'm afraid of the lack of resource. I'm afraid of the lack of PPE. I think neurosurgical procedures will be the last to be performed, unfortunately, because of the resources it takes to do these type of surgeries often. And if you don't have adequate ICU beds, etc., then also about the outcome, can it be as good as you would like? What can we do? I think in our hospital, we're already recycling our surgical masks because apparently there's a protocol for cleaning them. I think we have to show solidarity. I think that's super important. We can make sure that the people there have access to exact same information we have. Make sure that in case of task shifting and sharing, there will be task shifting and sharing there as well, that they get the same training, that they give the same information and the same PPE as we're getting. So we can make sure that there's adequate communication. We can make sure that there's that we send resources and perhaps trained people so that there will be not so much task shifting and more task sharing. So I think those are some of the things we can do. Also there we should advocate for the neurosurgical patients. Like I mentioned, I'm afraid that because of the number of resources it takes, neurosurgical patients might be some of the first, to suffer from the pandemic. So we can continue to advocate for these patients and help our colleagues in low and middle income countries and ask them, what do you need? How can we help? Communicate. They will be facing greater challenges than we do And we can perhaps see how the frameworks we are using can help them too. I think communication, information, protection, those are the things we have to offer, and I think we should.
Very good. So we're closing in on an hour now. We'll ask one more opportunity for questions you can write in, but overall, I think it's super helpful to kind of walk through the ethical challenges that we're facing currently in neurosurgery, and we'll probably continue for an unforeseen number of months and hopefully not years. But this also may be, as many are discussing, this might be the first big pandemic, but there may be others, slightly different ones to follow. And I think it causes us to look very closely at our health system and really team together with these organizations. For those who are young neurosurgeons, I think applying these frameworks yourself and every patient you see, being very proactive about the discussions about what would the goals of care be for that patient is something that we all can do. And if there isn't any ethics group at your hospital or committee, this is something you can bring up to your supervisors or potentially champion yourself. Any other closing remarks, Marike?
Well, I fully agree with Faith. And it's not bad to admit that you feel moral distress right now. I think every one of us feels some form of distress, anxiety. Please talk about it and think, what can I do? What can we do? And continue to advocate for your neurosurgical patients. And if you do that, then you're already doing so much. And thank you all much for joining us today.
All right. With that, I'll close this webinar for today. This will be available on our YouTube website, and we'll be having upcoming webinars in the future. The next one will be this coming Wednesday, April 29th, with Dr. Tim Smith from Brigham and Women's Hospital, and that will be about digital phenotyping and how COVID-19 pandemic will likely change a lot of the digital health going forward. All right, thank you everyone. Stay safe and healthy, and thank you all for your service. Thank you, Dr. Brookman.
Thank you.